Good afternoon, everyone. Thank you for inviting me to participate in this event. I'm going to talk about the use of robotic-assisted colectomy for cancer at MSK. As many of you probably know, at MSK we have been using robotic for the treatment of colorectal cancer for years. Now, why we decided to use robotic for colectomy, which is quite debatable? I think there are three main reasons that I will give you. One of them is the fact that we have lower conversion rates. I think we believe that we can do a better mesocolic excision, and I think there can be a number of talks about this topic in this symposium. And also because we can perform intracorporeal anastomosis that we believe has an advantage for the patients, and I'm going to just cover all these three topics in the rest of my talk. We know that conversion has a price. We know this from the COST trial, that patients who undergo minimally invasive surgery and need to be converted to open surgery pay a price. They have the longer length of stay, the greater use of narcotics, and probably more complications. So avoiding conversion is important. But when you look at the trials on open versus laparoscopic surgery for colon cancer, the conversion rate was quite high. I know that this is all data, but probably still the conversion rate is not trivial nowadays. And there is evidence, like this National Surgical Quality Improvement Project analysis from a few years ago, that suggested that conversion rates were lower when you use robotic compared to laparoscopy for low anterior resection right colectomies and even probably for left colectomy. So that's one of the reasons why we do it. In our hands, the conversion rate today is quite low. The other argument to use a robotic versus laparoscopic colectomy for us is the issue of the completeness of the mesocolic excision. You can see in these slides, in the prospective randomized trials comparing open and laparoscopic colectomy, the number of lymph node retrieve was borderline with what is recommended by the standard guidelines of having a minimum of 12 lymph nodes. And probably that is still correct today. Many laparoscopic colectomies result in a very low number of lymph nodes, and that's a concern. As you can see in this slide from the Japanese group, we classify the lymph nodes in the colon in 4 groups: epicolic, paracolic, intermedial, and apical. And I think with laparoscopic colectomy, sometimes only the paracolic lymph nodes along the marginal artery are removed. Even the lymph nodes along the named arteries that we would consider a D2 are probably neglected in some cases. Not even speak about the central lymph nodes that they will categorize a resection as a D3. So I think this is an area of potential improvement, from the laparoscopic approach. And again, we have plenty of evidence that the number of lymph nodes, both in patients with stage 2 and stage 3 disease, have an impact in survival, and that's the reason why doing a good lymphadenectomy is good for the patients. We have cases like this patient of mine who had colon cancer. There is a lymph node there along one of the vessels, probably a right branch of the middle colic. The patient had a colectomy, and then a few years later comes back with a recurrent that it was probably a lymph node neglected at the time of the initial procedure. So this is what you can see sometimes, and is not an uncommon source of recurrence in patients with colon cancer. So why is the number of lymph node retrieved in laparoscopic colectomy relatively low? I think the laparoscopy is still technically challenging for obvious reasons. You work with rigid instruments that don't articulate, that don't have much dexterity. People feel uneasy dissecting along large vessels with these instruments, so they tend to stay in the middle of the mesentery, and they leave even a portion of the named vessels and the what we would be considered D2 lymph nodes behind. Sometimes the mobilization of the mesentery is incomplete, particularly in the right side, the portion of the mesentery lying over the duodenum and the pancreas that leaves some lymph nodes in that area, as I saw in that image. And again, the division of the mesentery with energy devices without identifying the blood vessels, just with the energy devices across the middle of the mesentery, is going to leave behind apical and central lymph nodes. So I guess that there are going to be a number of presentations talking about the standardization of surgery for colonic cancers and the benefit of central vascular ligation with CME, where we normally are supposed to take the lymph nodes. The ligation of the vessel is perceived by surgeons as the most difficult part of the operation. And when you consider the different segments of the colon and what part of the colon you're going to be removing, the control of the vessels is more difficult in the right colon and in the transverse colon. people don't feel very familiar dealing with the branches of the Henle vein or with the origin of the middle colic vessels when we are dealing with the transverse colon. So that's the reason why we tend to leave the lymph node behind, because of the technical difficulty and the unfamiliarity of the surgeons with the dissection along those areas. Now, in our own institution, we have looked at the lymph node yields, comparing open, laparoscopic, and robotic right colectomy, and we look at the total number of lymph nodes. It was clearly higher in the robotic right colectomy, but in this paper we came out with a way to analyze the number of lymph nodes according to the length of the specimen. Of course, you can get more lymph nodes if you get a longer specimen. That doesn't mean that you get more mesentery. In this case, we standardize by the length of the specimen, and the robotic right colectomy came higher when we look at that ratio of the lymph nodes by the length of the specimen, meaning that probably there is more mesentery and more lymph nodes get in the apical versus the paracolic area. Now, the third point I want to touch in this presentation is the issue of the intracorporeal versus extracorporeal anastomosis. And I think it becomes important because doing intracorporeal anastomosis allows you to place your incision in the optimal place where you want to do it. We know that the rate of incisional hernia is greater for incisions placed in the midline. Of midline incisions has a much lower rate of incisional hernia, and that is something that has been known for years. In this paper from the Cleveland Clinic, specifically the fan steel incision, just the one doesn't cut any muscle and is a transverse incision, everyone is familiar with that, is associated with a lower rate of incisional hernia compared to other incisions in the abdominal wall. And that is our preferred incisions when we can do intracorporeal anastomosis. Now, we look as a kind of background information, what was the rate of incisional hernia after laparoscopic or robotic right colectomy? And when we were using midline incision, at approximately 2 years, the incisional hernia rate was approximately 20%, maybe even more than that. Our patient had cancer and they all come for follow-up, so our follow-up for our patients is quite good. And the rate of significant incisional hernia is 20%. Not all of them had surgery because, again, these are cancer patients and some of them, they're going to have recurrence and they are not going to be treated for a benign condition, but many of them do have operation for the incisional hernia. So it's not a trivial problem. So I say if you follow these patients for 5 years, probably a quarter of them, maybe a third of them, will have incisional hernia. And that's independent, of course, whether you do laparoscopic or robotic. That has to do with the location of the incision. What is clear is that a robotic approach, because of the dexterity of the instruments and a much easier way to suture intracorporeally, the robotic facilitates the creation of an intracorporeal anastomosis. And again, this is it was reported by this paper already several years old by Dr. Choi and his group from Korea. Now, we have done a review of my own experience looking at the outcomes of patients who had intra and extracorporeal anastomosis for robotic right colectomy. And in this slide, I represent the position I use, the position of the trocars and the incision. When I'm going to do extracorporeal anastomosis, I place the camera in the midline and then enlarge that opening for the incision for the extraction of the specimen and the creation of the anastomosis through the same hole. I have my working trocars in the left side along the midclavicular line and the assistant port with the air seal in the flank. When I'm going to do an intracorporeal anastomosis, I place the camera a little bit off the midline and then I do a fan steel incision. The operating ports and the assistant port are in the same side, in the midclavicular line and in the flank. So the only thing that changes is the incision, a fan steel, when I do an intracorporeal anastomosis. And I review this experience because I was the first one to adopt intracorporeal anastomosis in my institution, and this is not a randomized study, but the use of the robotic intracorporeal anastomosis was based on the instrument and in the help that I had in the operating room. The characteristics of the patient were very similar. Of course, it took longer time for me to do an intracorporeal anastomosis. The conversion was only less than 1%, only one patient in the extracorporeal group had to be converted. The length of the incision was the same. The rate of complication was also the same. Any complications, approximately 13-14% of the patients. Surgical site infection also the same. Length of stay, 4 days versus 3 days. That was significantly different, and the readmission rate was relatively low in both cases. Now, when it comes to the incisional hernia, we found a difference than we expected. We have more hernias when we use the midline to perform the extracorporeal anastomosis compared to the fan steel incision when we did intracorporeal anastomosis. And we do side-to-side isoperistaltic anastomosis with the stapler usually coming from the left upper quadrant 12 millimeter trocar, and then closing the common enterotomy with sutures. So, but this is our result that we just published in DCNR earlier this year. So I think in summary, the current robotic platform enhances visualization, dexterity, and surgeon control during minimal invasive colon and rectal surgery. That results in lower conversion rates compared to laparoscopic surgery. I think we also do a better complete mesocolic excision and achieve a greater lymphadenectomy. Is associated with less complication and probably shorter length of stay, and again more complete oncological resection. So again, these are the reasons why we have adopted the robotic platform for the treatment of colon cancer at our institution. Thank you.